First, Dr. Juan Osorio Iriarte is a urologic surgeon completing a pediatric urology fellowship at Fundacio Puigvert in Barcelona. Dr. Iriarte is passionate about advancing care for complex and underrepresented conditions. Dr. Iriarte will be discussing the importance of standardized follow-up of care of patients with complex urologic conditions. Specifically, the title of this talk is Critical Need to Standardize the Follow-up Care of Patients with Complex Urological Conditions that Require Catheterizable Channels. Thank you.
So thank you very much. Good afternoon, and I hope everyone's doing great and full of energy after this lunch. I want to thank the ABC and, of course, the Boston Children's Hospital for their warm welcoming. And many thanks to all the speakers and the audience. I firmly believe that it is important to use a clear and accessible language so everyone gets to understand what we try to do and what we're trying to say. So let's see. Severe impairment of bladder function can arise from various causes, including bladder exstrophy and epispadias. So the therapeutic strategies focus in two tasks: preservation of renal function and, of course, control of micturition. For those purposes, a continent, low-pressure, high-volume bladder is essential, and this is achieved by ensuring a complete emptying of the bladder. Of course, always thinking about the best quality of life for our patients. There are multiple surgical variations for managing bladder emptying, and the choice depends on each patient's individual anatomy, needs, and functional goals. Some patients may have funnel bladder neck and void without the need of catheterizable channels. Others may require a catheterizable channel with or without the need of a bladder neck reconstruction, or even a complete bladder neck closure and a catheterizable channel, of course. Each approach aims to support the effective bladder management, whether through spontaneous voiding or intermittent catheterization, and is tailored based on what will provide the safest and more efficient and most independent outcome for the patients. And it's also I need really to say that decreasing the bladder capacity can be effective treated with oral medication, but also in some children, bladder augmentation has to be performed. So, however, some of the individual accessing the urethra can be difficult, uncomfortable, or not possible due to physical limitations or condition. And in these cases, having a catheterizable channel must be essential. But then what is a catheterizable channel? It's a small passage created to help to insert the catheter and empty the bladder, and it allows a safe and comfortable urine control. It is made from either the appendix, which is called Mitrofanov, because it was described by Dr. Paul Mitrofanov on the 80s, or in some cases where the appendix is not used, it can be used, we can use some piece of intestine that we call Monti or Casale, depending on the sutures that we make. But all of them are tubes to catheterize. And these tubes connect the bladder and exit through the skin, through the belly button in most cases, which also depends on the length of the tissue. And this opening to the skin is called stoma, and it serves as an alternative pathway to the bladder. So then why it's important to follow the patients that are users of catheterizable conduits? Because they may have complications during their time. They can develop some stomostenosis, which are, for example, when the patient has difficulties on the catheterization. Maybe it's because there is a decrease on the caliber of the tube, or maybe leakage. It could be because of the incontinence mechanism of the stomach, or also because of the bladder. Maybe a false drag when the patient tries to catheterize, but it's not possible, and they can injure the tissue, and other things like necrosis, fibrosis on the polyp formations. But if this appears and if it gives some symptoms to the patient, we must be aware and we must try them before they get a huge complication. So the appearance of the complications can be variable in time. and some of them may require some sort of reintervention. So our experience at Fundació Puigvert in Barcelona, we are reference center for bladder exstrophy, national center, and now global center for managing this pathology. We have a huge amount of patients with bladder exstrophy. And what we do, and I have this question about what happened with these catheterizable conduits in these patients. So we did perform a study to check how this patient goes in long term. So we followed the patients through 21 years and check what happens to them. We perform a descriptive analysis. And at the end, from our bladder exstrophy patients, just 40 of them has the catheterizable conduit. And the medium age at the moment of the study was 30 years. Most of them were female. Most of them has bladder augmentation with colonic tissue. All of them, of course, had catheterizable channels, but most of them were Mitrofanov, some of them Monti and Casale. And during these 21 years, just 25% of them had leakage between catheterization, when 7 of them was because of the trochanter overactivity, so they were treated with medication or even Botox injection too. 3 of them had a failure of the continence mechanism, so they have to had a surgery to help in this part, with a median time of intervention of 3 years. 10% of them had difficulties in catheterization during this time, and 2 of them were because of stomach stenosis, so they required dilations. 1 of them was because he developed a polyp, so we have to resect the polyp, and 1 of them needed a stomach remodelation, with a median time of intervention of 19 years. And 25% of them developed benign polyp tissues. And just 1 of them required a redo of the conduit. So what have we learned? Just the standardization is critical, and it ensures the evidence-based care for all the patients, allowing for early identification of complications or disease progressions. It improves patients' outcomes and quality of life. It facilitates communication among the multidisciplinary teams and reduces the unnecessary tests and hospital visits. So what elements of an ideal standardized follow-up plan should we take into account? First, of course, the personalized, because every patient with bladder exstrophy is on own world. Clear timeless for follow-up. For example, at our center, what we do is that we follow the patients every year. They have to come and they have to stay with us, and we perform the studies that they need. Also define criteria for intervention in cases the patient has difficulties in catheterization or what they need. We have to listen to what our patients says to try to check and help them if we need to intervene something. Using electronic health records to track the follow-up. In our center, the patients can call us. In our center, the patient can send us emails. So we keep in touch with them, not just because we see them every year. I mean, if the patient calls us and say something, we can take the patient into the hospital before this year and do what they need. And of course, the inclusion of patients' education and self-monitoring strategy like this. We also do these educational congresses and conferences, so the families of the patients and the patients get educated about how they can be treated or what we can do for them if they need something as a patient with bladder exstrophy and users of catheterizable conduits. So concluding, my aim is not to get you scared about the catheterizable channels. On the contrary, to tell them that this is valuable tool for achieving urinary continence, but the long-term follow-up protocols are essential to identify these potential complications, and the early detections of these complications help us prevent long-term consequences and improve patients' outcome. Thank you very much, and I hope you enjoyed the presentation.